सीधे बैठ जा तुम भी।
मैं ऊपर में टांग दर्द होती है, नहीं बैठ सकती है।
कुर्सी कर दूं यहाँ पे?
इट्स ओके, आई एम फाइन।
So Bharat and Abhay, you can see my screen clearly.
We can see, but there are black.
There are black. Now?
No, I think, yeah, I think still it is, still they are visible still.
Now?
No, it has increased in size, small. Yeah, the one is gone.
So you can see on the top of the screen?
That's right, on the top of the screen and on the right side of the screen.
Yeah.
Spine Wellness is clearly red and the Care Foundation, but on the right side, there is a small little strip on the black and at the top of the screen.
तो प्लेन में खेलते खेलते मैं लखपति बना था, 1 लाख की राशि सर उस टाइम हम हमारे सारे सपने पूरे नहीं कर पाए, तो 1,60,000 से सर हमें आगे वाले हमारे पूरे सपने कर सकेंगे सर। तो मेरी जो जॉब का फंक्शन है सर, मुझे टूर पे ज्यादा दिन, जो मुख्य सपने ट्रेनिंग के साथ रहना सर।
Good evening, HS.
Hello.
Yeah, we're just starting, sir.
Okay. Good evening. All the best.
Thank you, sir. Thank you. Good evening, everybody. Welcome once again to the next in the series of webinars of Spine Wellness and Care Foundation. We would request all participants who are not speaking to kindly keep their devices on mute. That we will be focusing on bone health and osteoporosis, fact and fiction today. You're aware that we had a webinar last month on the topic, where we discussed various aspects per se. We discussed that osteoporosis is a generalized reduction in bone mass and bone quality. We discussed that it is like a global health epidemic with a very high prevalence rate across the world. We also discussed that it is a very high contributor to care costs, with very high annual estimated costs associated with this condition across the globe. Urbanization and sedentary lifestyle is leading to an increase in osteoporosis, and due to the aging of the population and changing lifestyle habits, this has further compounded. We also know that Indians are especially at risk for osteoporosis, show the highest prevalence, and tend to get it at a younger age. It is a misconception that osteoporosis is a women's disease. While the disease is more common in women, men are also at risk for osteoporosis. We also know that osteoporosis is unfortunately substantially underdiagnosed and undertreated. Osteoporosis is a silent disease. We do not have symptoms until there is a fracture of the bone. But once it manifests with a fracture, there is generally a downward health spiral leading to spinal deformity, decreased lung and abdominal capacity, impaired function, loss of appetite, sleeping problems, decreased activity, more bone loss, increased fracture risk, increased lung problems, comorbidities, and an overall increased mortality per se also in addition to the morbidity. We are also aware about the modifiable and non-modifiable risk factors for osteoporosis. And since osteoporosis is largely a silent disease, it becomes all the more important to know about these risk factors so that one can get screened at the right opportunity to prevent this debilitating disease. And so in our next in the series of webinars, we decided to focus on prevention and management of osteoporosis and also monitoring the response to treatment for osteoporosis. And like in the last webinar, we have two great stalwarts who have contributed a lot in the field of osteoporosis. Joining us today, Dr. Bharat Dave is joining us from Stavia Spine Hospital and Research Institute, Ahmedabad. He is the director and senior spine consultant at this institute. He is the chair of the Spine Registry Committee of the Association of Spine Surgeons of India. He is a senior AO Spine faculty. From Mumbai, we have Dr. Abhay Nene, who is the consultant spine surgeon, VR Spine. He is available at Leelavati, Preach Candy, HN Wadia Children's Hospital, all very prestigious hospitals. He has special interests other than osteoporosis in pediatric deformity and spinal tumors. He is the AO Spine Asia Pacific Chair-elect, AO Spine Asia Pacific Educator of the Year 2018, and has wonderful hobbies, moonlights with classic rock band, the Flunkies, enjoys cross-country cycling, mountaineering, and road running. So we will start with the first question and throw it across to Dr. Abhay Nene. How can we prevent osteoporosis? Over to you, Abhay.
Thank you, Dr. Chabra, as usual, for getting us all together for this wonderful forum where we end up learning so much. And, this cross interaction helps us further our cause of osteoporosis prevention for all by some time in this century. So thank you again, Dr. Chabra. You've been a stellar act in this field. So the question itself answers many doubts that how can you prevent osteoporosis, which really means you can't really treat osteoporosis. And that's a loud and clear message that comes across from everyone here, that prevention seems to be the only treatment modality available for osteoporosis, because once you develop osteoporosis, there's very little in terms of pharmacology that we can do to turn it around. So if you remember from the discussion the last time, we build our bones in our growing years, which is up to the age of 35. And those are our earning years. And in this time, the more bone we create in our systems, the better off we are going to live off that bank balance for the rest of our life. I mean, that is the fundamental understanding. So to prevent osteoporosis, you need to be active. You need to have healthy ingredients. You need to be doing exercises that challenge your system, that challenge the muscle, resistance exercises, load-bearing exercises, not only for the lower limbs, but the upper body. In that growing age, before the age of 35, at least before the age of 45, to develop a great bone bank for it to last you for later. There are some non-modifiable factors, which is genetics and hormonal status, which you really can't play around with. But the modifiable factors, which is nutrition, adequate calcium, adequate vitamin D, adequate proteins, and exercise are the two factors that you can definitely work on to prevent osteoporosis.
Thank you, Abhay. You have summed it up very well. Dr. Bharat Dave, you also wanted to add something to what Abhay has mentioned? Bharat, are you on mute?
Sorry, yeah. So one way, there are many ways by which you can prevent or rather delay the onset of osteoporosis. And that is something which I would like to highlight is the primary prevention and secondary prevention. So primary prevention, as mentioned by Dr. Nene, that we really need to go for the bone bank concept. And it is the disease of childhood. Remember, our kids, they don't go out and they are not exposed to the routine physical exercise which we used to have. And that is where, this childhood disease word should come. So that is something which should be poured into the society, into the mind of families, where we really need to have the primary prevention. We are not into the primary prevention yet, but we should be considering the secondary prevention. Once one fracture has occurred, second is on its way. We should be highlighting medical management. We should be improving the mobility as much as we can. And we can certainly implement that mobility part, weight bearing exercise in the primary prevention. So basically awareness, and awareness, that is what we are here for. So we really can certainly delay the onset of osteoporosis by these measures. Thank you.
Thank you, Dr. Bharat Dave. I think because this is a very important aspect, which all of us should be very thoroughly aware about, as very rightly pointed both by Dr. Abhay Nene and Dr. Bharat Dave. I'd want to reinforce by mentioning again that the most important measures to prevent osteoporosis are weight-bearing exercises, diet, healthy diet with ample amount of proteins, vitamin D, calcium, maintaining the body weight, avoiding smoking and alcohol, and avoiding processed foods. So, Dr. Bharat Dave and Abhay both very rightly pointed out that the skeletal mass in old age is directly proportionate to the skeletal mass acquired during childhood and adolescence. So you should look into bone health not as you are aging, but right from childhood, because 10% increase in bone mineral density could delay the development of osteoporosis by 13 years. And although genetics will determine up to 80% of the variability in individual peak bone mass, factors such as nutritional intake and physical activity will help a child achieve optimal bone strength. For the benefit of all of you, would want to point out that right from childhood, there is continuous bone formation and bone breakdown. During the younger years of age, bone formation exceeds bone breakdown, and that's why the bone mineral density keeps increasing during childhood, and the individual peak bone mass is achieved by the age of around 25 years, that is around third decade in life. And after that, it starts going down slowly, and various risk factors may exacerbate this reduction in bone mass. One of the factors is early menopause, but you need to look into it, and this has been very amply emphasized by our panelists. So with that, we come to the next question, which we are putting across to Dr. Bharat Dave. What is a healthy diet for healthy bones?
So ideally, one can incorporate a lot of things as a healthy diet, but in general, the milk and the milk products, they provide the calcium which is ready available. So how one should calculate? 1 milligram is equal to 1 ml. That is how one should calculate. There are food like, the ragi that has got the maximum, along with the sesame seeds, they also have the maximum. And there are, the proteins, they have the maximum. Rajma has got the maximum as well. So there are food, which contains high calcium, but at the same time, how much you retain after cooking it, that remains a big question as well. So if at all you want to really take home something, then the milk and milk product, consume as much as you can, because you cannot have 1 liter of the milk for 1 gram of the, so that is where one can really add on the calcium tablet as well. Over to you, sir.
Thank you, Bharat. Abhay, do you have to add anything to what Bharat has mentioned?
Actually, he summed it up well. All I want to say is that most Indian food does not contain enough calcium. So you should be just cognizant of that and ensure that, you have some supplements in your diet.
Yeah, so thanks Abhay, and thanks Dr. Bharat Dave. So healthy diet should be rich in calcium, and Dr. Bharat Dave has mentioned some of the products which are rich in calcium. So dairy products, fish, pulses, he mentioned. But for healthy bones, you also need adequate vitamin D. Which is available with cod liver oil or fortified foods, high protein diet, right, which is there in plenty of the food materials. You need also vitamin K, which could be found in leafy green vegetables, spinach, cabbage, magnesium, again, green vegetables, legumes, nuts, seeds, fish, and dried fruit, zinc, again, available in poultry, whole grain cereals, pulses, legumes, and dried fruit, and carotenoids, which are available in leafy green vegetables, carrots, and red peppers. So for our young colleagues, you would be now aware about why your parents and elders keep talking about having adequate amount of vegetables also, and a balanced diet, because you need that all in order to have a healthy diet for healthy bones. So coming to Dr. Abhay Nene again, do I need to take calcium and vitamin D supplements? If your patient asks that, what would your answer be?
Unfortunately, the answer remains a big fat yes, because our diet is inherently deficient in calcium, and it has been shown that even a rich non-vegetarian diet supplies about a maximum of 500 milligrams of calcium every day, and our daily needs pre-menopause are 1,000 milligrams a day. Post-menopause for women, it is 1,500 milligrams a day. During pregnancy, it is 2,000 milligrams a day. And in males after 70, it is 1,000 milligrams a day. So sum and substance is that our diet is not adequate in giving the amount of calcium that is really needed, and a supplementary source is needed. And this, this multiplies manyfold in the vegetarian diet, which is seriously low in calcium. Besides this is vitamin D, and a lot is said about going out in the morning sun to get vitamin D, and that's a huge myth, because there are some facts that I want to stick my head out and tell you. There's that the sunlight that really gives you vitamin D, which is stored in your fat under the skin, the sunlight that converts that into activated vitamin D is the afternoon direct sunlight, when the rays are directly on your skin and not the oblique rays in the morning, which otherwise feel fresh to you. So it has to be a burning afternoon sun that scorches your skin, which none of us are prepared to go to. Even if we did decide to, we are dark skinned, and dark skin needs much more sunlight than what you and me can manage in the Indian conditions. Even if we do, most of us who live in cities are covered with smog, and smog tends to filter the ultraviolet rays, and very little of the genuine UV light reaches your skin. Even if you go out in the in the sun in the middle of the day, in a half sleeve shirt. So genuinely, vitamin D deficiency becomes pandemic in our country. And I think all Indians should be taking vitamin D supplements, and especially Indians who live abroad in the Northern Hemisphere should doubly take vitamin D supplements. Personally, I check my vitamin D every year, and I take 60,000 milligrams of vitamin D every month.
Thank you, Abhay. Bharat, you wanted to add something to that. I think you have given some slides also in this regard.
Yeah. So basically, intestinal absorption of calcium is not, it is not efficient. I think particularly cereal-based diet. Intake of dairy calcium is usually inadequate, as mentioned by Dr. Abhay Nene and by Dr. Chabra earlier as well. Sunlight, what Dr. Nene, I would really tell and endorse that we need 4 hours of real afternoon sunlight in order to convert that active into vitamin D. And we having the dark skin, really that is also not sufficient, and it is practically not possible. It will burn the skin. So let's not do that. Let us accept that fact. And most of us now remain indoor as well, and where the sunlight is also limited. So let's not try to get something from the sunlight and get exposure. The old golden days were there, where people used to go out of the sunlight and do the farming and all that. So that is where it was not required. Something that is happening overall in the environment, that is what probably is an alarming fact. Vitamin D and vitamin B12 deficiencies are seen. Something which is related to we have not still failed to understand. Something is happening there. So that is what really should be understood, should be taken with a pinch of salt, and we should give vitamin D, and vitamin D injectable should be taken with due care. Because if suppose you are giving vitamin D injection, particularly my orthopedic colleagues, if you do that, overdose of vitamin D is a known fact as well, and it can cause lot of side effects, because vitamin D is a fat soluble vitamin. So if at all one want to give injectable vitamin D to begin with, and after maybe 6 months one can go on to the oral supplement, if you feel that patient is not compliant with oral vitamin D. Next slide, sir. Yeah, sorry, done, sir. I think for this question it is
right. So we need to take calcium throughout our lifestyles, but as mentioned by Abhay and Dr. Bharat Dave, we need to supplement calcium during some periods of the life, especially when there is increased requirement. So where the body intake through the diet cannot meet the requirements of calcium. So you can see here the requirements of calcium throughout the lifetime. So you have to take adequate amount of dietary products which can supplement your calcium. You need to take sunlight and vitamin D supplementation. And as mentioned both by Dr. Abhay Nene and Dr. Bharat Dave, the season and latitude, use of sunscreen, city smog, skin pigmentation, and a person's age are some factors that will affect how much vitamin D the skin can produce through sunlight. Recommended by the International Osteoporosis Foundation and WHO is to get 10 to 20 minutes of sun exposure to your bare skin outside peak sunlight hours daily without sunscreen, and taking care not to burn. A daily intake of 400 to 800 IU of vitamin D is a straightforward, safe, and inexpensive means of prevention. And those who take calcium supplements, most of the calcium tablets have 800 IU of vitamin D within them, so that this requirement gets met. And calcium supplementation should especially be considered when there is inadequate dietary intake. And Dr. Abhay Nene mentioned that intake of calcium is suboptimal in more than 50% of the population in India. During increased demands, again, you need to take calcium, that is pregnancy, lactation, childhood. And if there is decreased absorption, right, you again need to take calcium, and this happens in post-menopause and women more than 65 years of age and men more than 70 years of age. Vitamin D supplements would be required in vegetarian diets and less sunlight exposure. So my question then comes to Dr. Bharat Dave. Can taking calcium cause kidney stones? So Dr. Bharat, you would want to respond to this.
I think the answer is yes and no both. If a patient, if an individual has got kidney stone tendency, then I think one should be careful about the salt that you take, because the excretion occurs from the kidney, calcium carbonate. And if you have the stone tendency, then probably one should not take it. Plenty of natural sources of vitamin D and calcium are available. So if at all one has got the tendency, then you can take the natural source of vitamin D and calcium both. Debate remains about the calcification in the blood vessel. This question was not asked, but I thought that this also needs to be discussed in such forum as well. And if you go to a cardiologist, he will say, do not take calcium because it will cause the calcification of the arteries. And if you come to us, then we will say you have to take calcium. So one has to really balance. So that is something which we consider, that natural source of the calcium should be taken if there is any doubt about this. The blood thinners, they affect the blood cell formation. Bone marrow is affected, and that is one of the cause of osteoporosis. Secondary cause of osteoporosis that is observed as well, particularly those who are on the clopidogrel tablet. Next, sir. Next slide, please.
Yeah.
Yeah.
This is
yeah. So
that comes to the which type of calcium subsequently, Bharat, right?
Sure. Okay, sir.
Or you may carry on. You may mention. Yeah, go ahead.
Yeah. So calcium salts which are preferred at the moment is calcium citrate maleate. That is what normally is preferred. And you know, that is what is at the moment preferred, calcium citrate maleate. Okay, sir. Thank you.
Fine.
We can, yeah. So what can we give in the calcium molecule? I think we can give the calcium phosphate, but then it is used in the hypophosphatemia, avoids the renal failure and may act as laxative as well. But then it provides only 25% of the calcium. We are talking about the calcium phosphate. Calcium carbonate, it gives us 40% bioavailability. It is absorbed in the acidic media and it often causes constipation. So that is something which one can take care of. Calcium citrate, it is better absorbed, less gastric irritation, common preparation in USA, but does not need gastric acid for the absorption. While the calcium citrate maleate, that is what is currently used by most of us, it has got a better absorption, but it is little more expensive and it is more effective in reducing the bone loss. Next, sir.
So you want to, yeah.
Let me add on. Yeah, sir. So when do we take calcium? This is an important question asked by many patients, and this is very important. So what happens that the immediately after the meal, to utilize the acidic pH, one can take it after the food, and it also causes less gastric irritation as well. Most of the time, what we advise to the patient, you take it at night so that the burping and all that is less, because you take it in the evening. Next slide. Moreover, it should not be taken with the tea because it prevents the tannic acid and it will lead to chelation. This is very important. If you take it with the iron, like, you know, any other supplement, like many iron tablets are available with little bit of iron into it, the calcium gets bonded with iron and both become ineffective. So make sure that we do not take, or one should not take, any multivitamin tablet with calcium tablet. Very important. And PTH surge is more at night, so absorption is more in the night hour as well. So that is why most of the time, in order to reduce the side effect of oral calcium tablet and in order to increase the absorption along with vitamin D, one should take it at the night or in the evening hours, calcium and vitamin D. Thank you, sir.
Thank you, Dr. Bharat Dave. Abhay, do you have anything to add on whether taking calcium leads to renal stones? You are muted. Yeah.
Just a short answer because Bharat was very elaborate. Taking calcium does not lead to kidney stones. There's no study to show that. And not taking calcium can also lead to kidney stones if your kidneys have that problem of the inner lining being defective to collect calcium, which means that your body contains far more calcium than that one pill you take a day. Your bones are a bank of calcium. So the kidney is in the process of forming stones. It's going to steal the calcium from the bone and create the kidney stone. Don't bother about that one calcium tablet you're taking. The general rule is that you got to weigh the disadvantage of not taking calcium versus the small chance of getting a renal stone out of the blue. If you're a stone former, I normally advise you to talk to your nephrologist who will know which type of stone you're forming, because there are different types of stones and they often give us the right preparation of calcium that you can take. So in general, there is almost nobody who has not taken calcium because of a renal stone issue, in my practice at least.
So thank you, Abhay. And since this has been talked about, but since this is a very important question which all the patients ask when you prescribe calcium, but the general opinion is that it can lead to formation of kidney stones per se. So should I take calcium? Does it not increase the predisposition to form kidney stones? Initially, there were concerns which were raised by the Cochrane review. And WHO and IOF also, IOF is the International Osteoporosis Foundation. It had also mentioned about a modest risk of stone formation. However, this has been challenged by new studies that recommend taking calcium with food for oxalate clearance. And these studies have found that it does not increase. In fact, diets with more than 1 gram of calcium per day could be protective against stone formation, as per some of the studies. And kidney stones are mainly composed of calcium combined with oxalate or phosphate. The calcium remaining in the intestine would impede the absorption of the products associated with the risk of renal stones, such as oxalates, and the intake of calcium supplements during meals would decrease the absorption of oxalates and thus the formation of stones. So this needs to be thoroughly understood, as both my colleagues have also pointed out. And when it comes to which type of calcium, that's also a common question that is asked, because you have the less expensive calcium carbonate available, and you have expensive ones like the calcium citrate. So generally, calcium carbonate serves the purpose, but sometimes it may cause constipation and bloating. But here again, taking with meals for adequate absorption is sufficient. Calcium citrate is sometimes required when individuals are likely to have gastrointestinal side effects. And especially in activated, we also need activated vitamin D in kidney conditions per se. So for optimal absorption, they say the dose of calcium should not exceed 500 milligram per dose, irrespective of the calcium preparation. So these all should be taken into consideration while taking calcium supplements per se. Now, we come to the next question. What are other common factors which affect bone health? And we'll put this question to Dr. Abhay Nene.
So aside of the dietary or the the raw materials, I think what is critical, as we mentioned before, is that you should realize that bone is a biological or a living organ, and it responds to strains and stresses, which means it's not just a building block. So basically, loading exercises affect bone health, and again, contrary to popular belief, if you go running out on the roads, you'll get stronger bones compared to if you sit at home and play video games. I think that's been amply set. So we got nutrition, we got loaded exercises, and then we got muscle building, because muscles are the key blood supply or the key nutrition supply to the bone. the stronger the muscle around the bone, the better nourished the bone is, and hence muscle building workouts are, the other things that at the right time, of course, at the time that you're younger and when you're building your bone stocks, building muscles is a good plan, and hence don't deny your child that opportunity to go out and play or to go to the gym, because it's a good thing. You would also want to know that things that are very common in the modern diet, which is salt, soft drinks, hydrogenated oil, and in adults, alcohol and smoking are all anti-bone forming agents. So if you have any of this, and I must say that even coffee, the good old, cup of coffee has been shown to be anti-bone production. So you got to be cognizant of this when you're working towards building up your bone bank. There's no one thing, but it's a combination of factors. Thank you, Dr. Chabra.
Thank you, Abhay. Very appropriately summarized. Bharat, do you have anything to what Abhay has mentioned?
I think, yeah. I think
I'll come to your slide. Yeah.
Yeah, I have a slide. Yeah. So common factors that are affected by is the diet. I think we should really have the proper diet, as mentioned n number of times in this webinar. But absorption, it is very important, because you see there are conditions which does not let the calcium get absorbed from the intestine, and whatever you do, whatever is taken, it won't absorb, and that is where one can have secondary osteoporosis, which is very important, like celiac disease. So all those things, they have to be considered when somebody who comes to us with the broken bone at a younger age. When vitamin D active form happens into the kidney, when the kidney is affected, sometimes we end up giving vitamin D3, that is a pure, it is a calcitriol. So that is very important, that sometimes we pump in to begin with whenever we have a patient with osteoporosis. So we have to check the calcium kidney function as well. And as mentioned by Dr. Abhay about the habits, one should be wary about one's own habits as well. Thank you, sir.
Thank you. Summarizing once again, a genetic factor is one of the most important factors which affect bone health. Age, as you age, the bones become weaker, and females tend to have weaker bones than male, but men are also predisposed to osteoporosis. In fact, studies in India have shown that the risk of fracture of the hip is maybe more in men than in women. So this could be called as the osteoporotic hip fracture. Abhay and Dr. Bharat Dave both talked about weight-bearing exercises, healthy body weight, reduced liability to falls, amenorrhea after onset of puberty or menopause, medicines like steroids and anti-epileptics, which can decrease bone strength. They also talked about smoking and alcohol, and some metabolic diseases like Paget's disease makes the bone weaker. So all these affect bone health and predispose to fractures or the predisposition to fractures per se. So now coming to Dr. Bharat Dave. Dr. Bharat Dave, what is the treatment of osteoporosis?
Next slide, please. Yeah, now we believe that, love me or hate me, but we really need to think about the disease osteoporosis, and along with that we talked about sarcopenia as well. So we have to remember these two duets together. They already are implanted into our body, and that is why we say that, like diabetes and hypertension, it is an aging disease, same way osteoporosis is aging too. Next, sir. Yeah, so once diagnosed, it's a lifetime treatment is must, and different drugs have different treatment actions. And that is where the role of sequential therapy comes. And I'll elaborate on that. Next slide, sir. Yeah, so this is a very important slide. So once the osteoporosis is diagnosed, when the pot is empty, let us consider pot and osteoporosis together. So when the pot is empty or half filled, that means patient has got osteoporosis. We need to fill up the pot. And how do we fill up the pot? That is with the teriparatide. Teriparatide is the molecule which stimulates the bone formation. osteoblasts are stimulated, and that's the only available molecule at the moment, which is a proven molecule where it stimulates the bone. So that is where we need to fill up the pot. We need to have the teriparatide in the beginning. So somebody who has got established osteoporosis with fragility fracture should be treated with teriparatide. Now, there are two more molecules, one which is shown on the right at the top, bisphosphonate, and one which is at the denosumab. These two are suppression of the osteoclast. This is a bit going technical, but one need to know these two cells. Osteoblast, they are the bone forming cell. Osteoclast, they are the bad cells, and they are the osteoclast, they eat the bone away. But then this bone away, it is eating, which is stopped by these two molecules, bisphosphonates and denosumab. So we need to add on after the pot of the bone is filled up with the teriparatide. If somebody who is the low risk fracture, then we can start even directly the bisphosphonate or denosumab. And these two molecules have its own function. So bisphosphonate should be given. I will come to that in a minute. And we should be supplementing the calcium and vitamin D. So now bisphosphonate, it is cost effective. Positive effects are like this. They are cost effective. Next slide. It is oral and IV, both are available. IV is available once in 1 year, and we should be giving it once in 1 year for 5 years, maybe 6 years. And alendronate is something which is oral, which is available. And this particular drug, alendronate, we should not take, we should take it empty stomach in the morning, but we should not lie down after taking it, because it goes into the esophagus. It causes the reflux, and this reflux can lead to ulcers into the lower end of the esophagus. So that is why we always tell our patient that whenever this drug is prescribed, alendronate, oral medication, bisphosphonate, to stop the osteoclast eating the bone away, this has to be taken with a glass of water. One should not lie down after taking the medicine. Zoledronic acid, we can give it every year, and there is a drug holiday, which is after 5 years or 6 years, 1 year, we should not be giving alendronate or zoledronic acid. What are the negative effects of bisphosphonate? Next, sir. Next, sir. Next. Yeah. So suppression of the bone turnover, it can cause osteonecrosis of the jaw. So if somebody is taking this alendronate or zoledronic acid, then probably if they complain of the pain in the jaw, it could be because of this drug which has stopped the osteoclastic activity. And high doses, a long-term usage of the alendronate or zoledronic acid, which can cause the atypical femoral fracture. So this has to be remembered. The negative effect is something which can be taken with the oral, as I mentioned, and patients usually are a lot more compliant with these two drugs, bisphosphonates. And drug holiday again has to be taken with due care. I ask the patient to put the, nowadays into the mobile that, okay, you put it, every year you are going to take this medicine. And one has to have the creatinine clearance regularly checked, or other one has to have the clearance mentioned or other measured before we start the bisphosphonate. Next slide, sir. Yeah, this is the denosumab. So positive effects are, it should be taken once in 6 months. The 10-year data at the moment is available. The 15-year data soon will be available as well. And there are no major lab tests required. Denosumab can be given in malignancy as well, and it increases the BMD faster. I tell to all my patients, make sure that you take it every 6 months. If you do not repeat it, because the osteoclast will start eating the bone, the osteoclast suppression is gone away, then the effect observed is a new fracture. So there is the wrong, a sort of effect, negative effect happens. So, and this denosumab is taken every 6 months, and patient compliance and adherence is quite good, provided the alarm is put after 6 months. One has to take denosumab every 6 months, and it is available, which should be taken for 10 years. And if at all patient is not compliant, not ready to take this denosumab, then one should switch over to the bisphosphonate. Now coming to bone forming agent teriparatide, the current data available, it is okay for 24 months. Usually all these drugs, they are once in lifetime. It is contraindicated in malignancy. Remember, anybody who has got history of cancer should not be taking teriparatide, because at the end it is hormone and it can increase the malignancy. It is a red label drug if it is given for a long time. So that is something which is seen by most of the generation Z. They will say, immediately look up the Google and say, oh, it's a red label drug. But it is not. In the real fact, it's a red label. It was given to rats at a higher dose for longer time. Then only it gave the malignancy to the patient. The cost has been the prohibitive, and it is subcutaneous daily use. And one really has to have the cold chain maintained. Beware of 5+1 or 3+1 such thing, because you see our freeze may not have functioning all the time, and if it is not, cold chain is not maintained, drug may not have its effect. So coming to the summary, bisphosphonate 5 years, drug holiday has to be considered. Atypical fracture of the femur and jaw necrosis, while the denosumab 10-year, good data is available and it is safe in malignancy. Along with calcium and vitamin D has to be supplemented whenever these molecules are given. So combined therapy, if I give teriparatide with bisphosphonate, do we have additive effect? No, it does not have additive effect. So very important, ideally one should start with teriparatide and switch over to either denosumab or bisphosphonate. Next slide.
Thank you, Bharat. So, Abhay, do you have anything to add to what Bharat has mentioned on the treatment of osteoporosis? You are muted. Yeah. So that's you. Bharat has said enough. Abhay says, right. That's great. So I would just want to reinforce, because this is an important topic, what Dr. Bharat Dave has mentioned. We have ample evidence and ample guidelines from various societies in UK, in US, in India. We have guidelines and suggestions from the International Osteoporosis Foundation and from WHO on how to manage osteoporosis. So treatment has to be evidence-based, but also experience-based. So treatment would include vitamin D and calcium supplementation. Exercises are very important, fall prevention, balance training, and use of assistance, protein-rich diet, and medications. These all, you have to have a comprehensive treatment, and just pharmacological treatment is not enough for management of osteoporosis. Exercises are important because they improve not only muscle strength and balance and reduce the incidence of falls by restoring confidence and coordination and strengthening the muscles, but they also maintain bone mass by stimulating bone formation and decreasing bone resorption. Now, you also need to reduce the likelihood of falls by correcting decreased visual acuity, reducing consumption of medication that alters alertness and balance, and improving the home environment, like avoiding slippery floors, obstacles, insufficient lighting, and handrails. So, how to treat and when to treat is also very important. So you need to calculate the fracture probability. So one way of calculating fracture probability is doing a bone density test. That's a DEXA scan. But then there are fracture risk assessment tools available, those developed by WHO, that is a FRAX. And if the probability of fracture is high, you need to treat. If intermediate, you need to reassess the probability with a bone mineral density at periodic intervals. And once it becomes high, you treat. If it remains low, you still again monitor. And those are the WHO guidelines. When it comes to pharmacological treatment options, Dr. Bharat Dave mentioned that there are a few options which build up the bone. They are called anabolic agents. And these teriparatide, Dr. Bharat Dave mentioned about it. In India, abaloparatide is not available, but it is available in some countries already. And then you have anti-resorptive agents which reduce the bone turnover, thereby building up the bone mass. And amongst them are SERMs, bisphosphonates, and denosumab. Right. So selective estrogen receptor modulators are less often used now, but in those who are immediately after menopause, raloxifene is one of the drugs which is often used. Estrogen used to be once used for management of osteoporosis, but it had side effects. So SERMs were developed, and raloxifene especially decreases the risk of breast cancer. And there may be some adverse effects like predisposition to deep vein thrombosis and hot flushes and increased risk of stroke and coronary artery disease, and these need to be monitored. Bisphosphonates can be oral or intravenous. Oral ones you need to take once a week or once a month also. And these may cause some gastrointestinal adverse effects like burping, and people may not tolerate it. Intravenous ones, once they came, helped in this regard, and there was an increased patient compliance. Adverse effects Bharat has talked about, and drug holiday also he has talked about per se. Now, teriparatide is like people take insulin every day just below the skin. Similarly, teriparatide with the same kind of an pen is injected below the skin by the patient themselves. Now it is also approved for use for more than 2 years. Till a short while ago, the FDA had approved it only till 2 years because the trials were carried on only till 2 years. Now it is approved for longer than 2 years also. But once you stop teriparatide, you need to have a sequential therapy, as Dr. Bharat Dave mentioned, with another drug, because immediately after stopping teriparatide, the beneficial effects start going down. So you need to add some anti-resorptive agent subsequently. There are some contraindications to use of teriparatide, and one of them is history of cancer or a malignancy, but there are various other conditions. So always we have to take these products under the guidance of a good physician per se. Denosumab also revolutionized osteoporosis management in a big way. It needs to be given once in 6 months only. So studies have found an increased compliance with denosumab than with oral drugs per se. And it has a good effect, as also Dr. Bharat Dave had mentioned, no major adverse effects, and it is safe also in kidney disease. Whereas teriparatide and some of the other drugs cannot be used if there is a kidney dysfunction. Again, once you stop denosumab treatment, you need to also add other treatment to that subsequently, a sequential treatment, as Dr. Bharat Dave mentioned about. And sometimes when there is very severe osteoporosis, you may need to combine teriparatide and denosumab both in order to have a better and a more rapid control of osteoporosis. So, Dr. Abenene, we will come to the next question. What is the role of monitoring the response to treatment of osteoporosis? You are muted. Abhay, you are muted. Unmute. Okay. I'll just allow. We'll wait.
Yeah, I got it.
Sorry.
It kept saying host not allowing the participant to unmute.
Sorry. I apologize for that.
So
Apologies.
it's a
So,
interesting.
Abhay, if you have anything to add to treatment of osteoporosis as well.
Not really, because Bharat covered it, and I think it's very technical for the average non-medico to understand. But I think they should just understand that they're bone-forming drugs and drugs that reduce the rate of bone loss, and you got to balance them. And that in your lifetime you have only 15 to 20 years of medications available, and hence osteoporosis is better prevented than treated. That's my two bits on this. But as far as monitoring response is concerned, it's a very, very important question, because it's every time you start a person on a relatively expensive medication for osteoporosis, their immediate question is going to be, what number am I going to see changing? And the only number that we have to hang on is the DEXA value, the -2, the -2.5, the -3. Now, unfortunately, this DEXA value is not a number, it's a standard deviation. And it takes a long time for that to change. And hence, also, it's not the absolute end all of your osteoporosis score. And it is one of many factors. So the first answer for me is that do not use the DEXA to monitor your improvement in your osteoporosis status. The clear-cut method of knowing that you're improving with medication is your general well-being. Your general health improves, your general capacity to, work, your pains go down, your body mass improves, your muscle strength improves, a general sense of well-being. That's your first goal. Increase in muscle mass, sometimes increase in body weight would be the other goal. And then sometimes over 2 years, you can monitor your DEXA and find out some change. At least there's a lack of reduction in the rate at which the DEXA is plummeting down. So there are more technical ways of monitoring whether you're doing well, which are some specialized bone resorption markers, which are blood tests, which we would not do routinely. We would just do them in special conditions where we feel that we're getting stuck with treatment. Bharat?
Thanks. Thanks, Abhay. Dr. Bharat Dave, do you have anything to add to this?
Bharat is also unmuted, I think. I'm muted, I think.
Yeah, it's okay now. I'm unmuted. Yeah. So another technical thing to talk about. I think there are 2 bone turnover markers which one should really know. At least one can think of these 2 bone turnover markers, because we often feel that this patient should improve, this patient should not develop the second fracture while patient is on the treatment, but still patient develops. So patient is not compliant to the treatment. When patient is not compliant to the treatment, how do we know? We can know by the bone turnover marker. And so we have to have the comparison. So day 1 bone turnover marker values are taken by the lab, and on the same values can be rechecked after the therapy is started. So that is one way. Second way, Dr. Abhay has said about the DEXA scan, and one can repeat it only after 1 year or so, or at least there is no drop seen in the DEXA value. And the third most important thing, the resistant osteoporosis. You see, this is something which I have seen in my career. So far, 2 cases, both did not respond to any of the medical therapy, and they continue to have the decline in the DEXA value. So this is something that is where the bone turnover marker may add on. But special investigation like vitamin D, TSH, creatinine clearance has a major value in order to diagnose the secondary osteoporosis, along with the PTH, magnesium and calcium value as well. Over to you, sir.
Thank you. I believe there is a question by Gunbir Kaurji. Would you want to ask any question that you have? Fine. So we'll come to you later. I think you have raised your hand, but we'll come to you a bit later. I will request my colleague to allow you to unmute yourself in a while, and you could ask your question then. Now, very rightly mentioned that the guidelines mention for bisphosphonates and denosumab, you review with a bone mineral density at 2 to 3 years and at 5 years. Normally, repeating a DEXA scan before 2 years is not useful, because it will not add to value, and changes have not taken place before that. So screening trial strategy has also been proposed by the International Osteoporosis Foundation based on the response to P1NP and CTX, what bone turnover markers were mentioned, were talked about by Dr. Bharat Dave and Dr. Abhay Nene after 3 months of therapy. I'll come to you shortly on this. For anabolic agents, there is no proper guidelines, but the issue is that when the bone mass increases and bone mineral density is bone mass over a particular area, so if you repeat a DEXA scan after a year of taking anabolic treatment, in fact, it may show a negative effect because the bone mass overall has increased. So a DEXA scan is not very valuable to monitor anabolic therapy. But bone turnover markers, as have been mentioned, are valuable there. Another thing is whether people are compliant to treatment or not, whether they have been taking the treatment as prescribed or not. And this can also be monitored by bone turnover markers, P1NP and CTX. If you take at baseline and 3 months after starting the therapy, if it has not decreased significantly, then it indicates that there is a low adherence to treatment per se. So you can monitor also the compliance by the patients onto whether they have been following the treatment properly or not. So I will we will come to some, we'll take some questions quickly from the participants. I will request my colleagues, can we unmute people so that they can ask their questions now? We had a couple of hands which were raised. Give me a second, I'll just get people unmuted.
Sarji, there are a few in the chat box as well.
Can we start with the questions in the chat box? So I could see one question here. How do you know you have deficiency? That you are prone to osteoporosis? So, Dr. Bharat Dave, would you want to take that question?
Yeah, I think after certain age, particularly postmenopausal women, I think one really should consider that yes, you are going to have osteoporosis. As mentioned n number of times in these webinars, that there is no way to diagnose that you are developing osteoporosis. It's a silent thief. And once the fracture has occurred, then you have lost significant amount of the bone. And the silent fracture is often seen, even on X-ray also, we pick it up and say that, oh, you have had the fracture. And patient says, I never had a fall. So that silent osteoporotic vertebral fracture is also seen. So postmenopausal, one can get the DEXA scan done. In the adult male after 70, one can get the DEXA done. These two age group, we should have the DEXA done. And then DEXA will sort of categorize that this patient has got the osteoporosis. But that is how one can really judge. In the last webinar, I talked about the loss of height, decrease in the height. That is also one of the effect which is seen in the skeleton. So if you feel that your height is losing, your clothes, the clothes size also changes. That also tells you that you may have osteoporosis, or it is you are getting the bone height is decreasing. Over to you, Abhay.
I think one thing that Bharat, you missed out was the family history. If the mother is osteoporotic, I mean, I invariably, because it's a, commonly passed on disease from mother to daughter. So if your mother is osteoporotic, who's suffered all this and she's now 70 and you're now touching menopause, it's probably a good time for you to look for osteoporosis in yourself. Also, ladies who tend to lose muscle mass or lose weight after menopause, the lean postmenopausal versus the ladies who tend to gain weight after menopause. The ones who lose weight tend to be, more likely to have osteoporosis, and a history of a fracture, a small, your toe hitting a table and your toe cracked, which you may pass off as, a nothing fracture, but it's still, is an indicator that you got weak bones. So insufficiency fracture or a fracture due to a domestic trauma also could deny that. So those are my 3 additional bits. I think Bharat covered it beautifully.
Yeah. One more to add, sir. Somebody who says that I have had severe pain and it resolved without medicine after a few weeks, they usually have the insufficiency sacrum fracture. So that is something which we have been seeing and we fail to identify because patient has not come to us, or patient may have come from a village and where they will give the history that, we had this. So that is something which is an eye opener as well and should be investigated accordingly. Over to you, sir.
Yeah, so if I were to summarize, this is very important because people need to know when they should get themselves screened for osteoporosis. And this becomes all the more important because osteoporosis is otherwise a silent disease. By the time it will manifest with a fracture, it's generally a lot of bone loss has already happened, and so the risk to fractures is very high. So there are guidelines onto this. They do not generally recommend a universal screening for osteoporosis. Everybody should not get screened. But all women 65 or elder and all men 70 or elder, they could get themselves screened for osteoporosis because age is one of the most important risk factor for fractures and for osteoporosis. The guidelines also mention that post-menopausal women and also those undergoing menopause and men between 50 to 69 years of age should get themselves screened if they have clinical risk factors for fracture. So what are these clinical risk factors for fracture have been mentioned by both Dr. Bharat Dave and Dr. Abhay Nene. And most importantly is a history of a fragility fracture. What is a history of what is a fragility fracture? A fragility fracture is a fracture without a severe injury, like a person walking and slipping and getting a fracture. Very often they say that the person falls down because of the fracture rather than the fracture happening because the person fell down, because the skeleton is not strong enough even to withstand the weight of the individual. Person falling within the bathroom and getting a fracture. So if there is a history of a fragility fracture in UK, they won't even do a DEXA. They will initiate osteoporosis treatment for you. Then, as Abhay said, a parental history of a hip fracture is a very strong clinical risk factor, and you should get yourself evaluated if you have this parental history. Then there could be other conditions like smoking, like regular intake of alcohol of more than 3 units per day, of conditions like rheumatoid arthritis, or if you have conditions like diabetes, long-standing untreated hypothyroidism, hypogonadism, early menopause. So conditions like this, you need to get yourself evaluated for osteoporosis if you are postmenopausal or men between 50 to 69 years of age. Remember, diabetics are predisposed to osteoporosis and even at a younger age may get it. So they need to be screened if they have long-standing diabetes per se. So this is very important question. And I think this should be especially taken care of. So there were other questions in the chat box. I think the question on how one pops in calcium and when while means it is very important. This is a comment, I think, by Komal on that doctors must counsel adequately on when one should take in calcium while prescribing it and when one should take it, right? Then Abhay made a very important point on avoid taking calcium with milk. Komal had asked that question. So there was another question, as vitamin D is fat soluble, is the absorption of vitamin D not proper in persons who have got their gallbladder removed? So Bharat or Abhay, who would want to take this?
Maybe Bharat, because I've already taken it on the chat box.
Yeah, right.
Yeah, I think one really this will remain a questionable, whether it will lead to fat absorption or rather the absorption won't occur. But generally we do not consider this, and we usually give it. So in theory, it should not hamper the absorption.
I would only want to mention here, because I see a question, a comment on sunlight, and this has been amply stressed upon also. Correct me if I'm wrong, Abhay and Bharat. Around 75% of Indians have been shown to have vitamin D insufficiency, at least, if not a deficiency. And India does not lack sunlight. So there may be factors other than just sunlight exposure. Abhay mentioned some of them, but I think there is a genetic predisposition also amongst Indians to have a vitamin D deficiency, and one should take this into consideration also in their diet and in supplements. Bharat wanted to say something in this regard.
One publication evaluated vitamin D 60,000 unit tablets, and that they have evaluated how much is the real vitamin D into it, and it varied from 2,000 to 80,000. So something which is lying there on the shelf doesn't mean that it is 60K vitamin D as well. So it may be worth measuring vitamin D to begin with, and then keep taking it, but not too excessive. Over to you.
Yeah. So any other questions from the participants? You can either mention it in the chat box or unmute and talk. I believe you can unmute now.
Dr. Chabra, Dr. Bathu here.
Yeah.
Good evening.
Hello, sir. Good evening.
Sir.
Good
This
evening.
is a very nice update on osteoporosis, its management and prevention. I like to compliment you all for apprising all the audience in a very nice way. I just want to thank you and compliment you both. That very well done, sir.
Thank you, Karan Mathur. I think it becomes all the more important when it comes from the mouth of someone who has been managing endocrinal problems throughout the life. So thank you. And I think we are all together in the endeavor to try to prevent osteoporosis and to manage it appropriately. Take the first opportunity to manage it.
Thank you once again, and good wishes to you all. Thank you, sir.
Thank you. Gunbir Kaurji, you wanted to mention something. Did you want to ask a question? So if there are no other questions, Abhay, what would your carry-home message be to the participants?
I think awareness, I'm so happy that all of you are here on a Friday evening, which means that you're keen to know about osteoporosis. It would be great if you can spread this message across to all your colleagues, because osteoporosis is a silent disease. You will not know when it takes the bone out of you and the strength out of you, and it's too late then. And we all are getting old. We are all, going to reach that age in the not so near, distant future, that we will, be in the osteoporotic zone. So it's best prevented. And to prevent it, the key is awareness. And I'm so happy that Dr. Chabra is bending backward. You all know that he's probably the busiest spine surgeon in the country, not only from the work he does, but from the institute he runs and the academic involvements that he has. And even then, he's taking this time out. And that is a big statement coming from our society, that we really need the public to be aware that there's something called osteoporosis, so the right measures are taken.
Thanks, Abhay, for your kind words. But I believe all of us are equally busy in our own practice, etc. So thanks for your kind words anyway. And Dr. Bharat Dave, what would your home message? Bharat, you may need to.
I think I
Yeah.
I got disconnected. Yeah, I think I have a couple of slides, Sirji.
Yeah,
Can
I
you
have
put up the
them on.
slides.
You can see them?
Yeah. No, I can't see them. Anyway, I think there is something wrong that has gone with my connectivity. I would like to add on two things mainly. Elderly population is increasing, and I would call this as an age quake. And we are in the era of age quake at the moment. Am I audible, sir?
Yeah, very much.
Hello.
Yeah, Bharat, we can hear you.
So we.
So we've lost you meanwhile. So I think till we get Dr. Bharat Dave back, the carry-on message, as Dr. Abhinane also very rightly pointed out, it's very important to prevent osteoporosis. It is very important to have a timely diagnosis to know that you have osteoporosis. It is not only medications which are important in management of osteoporosis. Equally important is a healthy diet, exercises, supplements, and fall prevention. All this is very important in management of persons with osteoporosis. So the dictum prevention is better than cure is very relevant here. So you have to build up on the bone bank right from childhood so that the peak bone mass is achieved appropriately, and then also try to work on the modifiable risk factors so that the bone mass is appropriately maintained. And if there are high risk factors for osteoporosis, you need to be appropriately screened at the appropriate time so that management can be started early, and the harmful effects of osteoporosis that we talked about can be prevented. So, Dr. Bharat Dave, are you there now?
Yes, sir. No, I have just rejoined again. So
Yeah.
probably I'm not sure what is happening, but sir, we are in the era of age quake. So what I was mentioning is that somebody hold my hand when I was young, when I was a child. Now it's time for us to hold the hand of our elderly in order to reduce the crippling done by these two duets, osteoporosis and sarcopenia. They both act together, and we really need to have the proper lights on, proper handling of this, the surrounding of the home, particularly have the railing at the home. All those things have to be done. And lifestyle modification, that is one of the most important message I would like to give at the end of this.
Thank you, Dr. Bharat Dave. Some problems with connectivity, but we have heard your very useful comments per se. Friends, this webinar was brought to you by Spine Wellness and Care Foundation, a charitable non-governmental organization established for improving the wellness of people with spinal ailments in India. We reach and serve persons affected with spine-related ailments medically and socially to help them lead better lives. Our main objective is to provide medical, rehabilitation, vocational, recreational, and social support for persons affected with spine and related ailments. You can reach us through email, through our website, through Facebook, YouTube, and Instagram. Our next webinar, friends, would be on 6th January, again a Friday, 7 p.m. And we'll focus then on another common problem, disc prolapse. And many of you would have known someone within your family or within your friends who have suffered from disc prolapse and would be eager to know how to prevent, and if it happens, how to manage this. Friends, let's join hands for prevention, early detection, and management of osteoporosis, the global health pandemic, but also all spine ailments per se. We look forward to having you with us in our next webinar on 6th January next year. Thank you, and thank you for your patience, and thanks for joining us today. Thank you especially to Dr. Abhay Nene and Dr. Bharat Dave for an excellent discussion, for covering the topic so well, and for taking out time from their busy schedule in the endeavor to create more awareness to prevent this disease, which, if managed properly, if prevented, can help in our leading a healthy and a wealthy life. Thank you. Thank you, everyone.
Thank you. Thank you. Thank you, Dr. Chabra. Thank you.
Thank you.
Bye-bye. Good day. Bye-bye.